and the event will explore emerging research. It will also launch the International Genetic ME Consortium, and we hope that it will be an opportunity to spark new collaborations within the field. As part of this event, we are also organizing workshops and opportunities for the community and people with lived experience to share their views on ME research and what they see as the priority. So the registrations are still open. If you go to the Action for ME Prime website, you'll be able to find out more about the conference program. And as mentioned, you can also attend online. If you'd like to find out more about the Prime project, you can go on the Action for ME website and there's plenty of information. For example, if you're a researcher or an industry representative interested in collaborating or joining a network within the ME and long COVID field, then we would very much encourage you to contact us at prime.partners@ed.act.uk. We also have a LinkedIn group, so feel free to check that out if you use LinkedIn. And I'll now hand over to Sean, who will tell you a bit more about the recently launched Prime PPI Hub.
Hi, everyone. Thanks for being here today. So we've recently launched the Prime MECFS Research Involvement Hub as a way of getting more people into patient and public involvement in research. We have managed to recruit a load of people with lived experience already, but that sign-up form is still there if anyone else wants to join us. And we are developing opportunities for people with lived experience of ME, be they people with the illness themselves, carers, or close friends and supporters, to work with research projects to help influence and design and shape that research. We're really keen to get in touch with more research projects. So if there's any researchers listening here who are interested in this and want support with their patient and public involvement work, please do get in touch with us. And yeah, there's lots more information on our website at actionforme.org.uk/prime. So please do go find out more about us. Thanks very much.
Thank you. So in this webinar, we'll be talking about post-exertional malaise, also known as PEM. So I think a lot of you have probably heard about it already, but it's considered one of the hallmark symptoms of ME. It's usually defined as a worsening of existing symptoms or the appearance of new symptoms following effort. So that could be, for example, physical or mental effort. PEM is now increasingly becoming a mandatory criterion for inclusion in most ME studies, but we know this hasn't always been the case. And we know that PEM has a huge impact on people's lives and functioning, yet has been quite under discussed and explored. So we felt it would be important to have a webinar on this topic. So I'm very pleased to be introducing our first speaker, Maree Candish, who is an MECFS research advocate and also a committee member of the Science for ME Forum. So Maree, over to you.
Thanks, Daphne. It's really good to be with you all today. So my presentation is based on the fact sheet on post-exertional malaise that the members of our Science for ME Forum have put together. Our forum is for people with MECFS and all the people who support them, including researchers. And we're dedicated to helping get better care, high quality research, and useful treatments. Up front, I want to note that there's a lot of disagreement about post-exertional malaise, from what to call it, who gets it, how to treat it or not. And that's because we don't know a lot about it yet, just the same as with ME/CFS. So diving into the definition, episodes of feeling much more ill than usual and much lower function. And I've bolded the ill there because people feel unwell. It's not just fatigue, which is often focused on. It follows exertion, including exertion that was easily tolerated before becoming ill. Typically a delayed onset. It can last for hours, days, weeks, longer. And the impact is not normal relative to the intensity of the exertion. As Daphne said, it's characteristic of the disease, ME/CFS, and has become a requirement for diagnosis. A key thing is the delay. Onset is typically delayed for hours or up to several days, but there isn't mechanistic certainty. The impact of exertion is cumulative. Various sorts of exertion can, over a number of days, can contribute to post-exertional malaise onset. It's a bit like a migraine. I think more people may be familiar with how migraines work, where one piece of chocolate probably doesn't give you a headache. But if you have a couple of pieces of chocolate and you have a bad night's sleep and it's a hot day, then maybe you will get that headache. The difference with ME/CFS is that, unlike for most migraine sufferers, there's actually symptoms in between the episodes, the flares of post-exertional malaise. So duration, it can be short, a few hours, but typically it's a lot longer, days, weeks. Somebody with mild ME/CFS, they might say something like, I went to a yoga class, one that I could have easily managed before I became ill, and I ended up in bed for 3 days. Lenny Jason's team in 2018 was doing some work on a questionnaire for post-exertional malaise. And I'm not quite sure if you can all see the chart there. You might need to move your people around a bit on your screen. But off to the right there, there's a big green bar. And that's the ME/CFS people. Over 70% reported that their post-exertional malaise lasted over 24 hours. The other thing that I want you to note from that chart is that people with other diseases were actually also being recorded as reporting post-exertional malaise. So the multiple sclerosis and the post-polio people, they were also reporting post-exertional malaise. And so the question is, does it happen in other diseases? And I don't know the answer to that. It's possible. But I think what we're seeing there in that chart is actually more an issue with the questions that are being asked, that aren't actually getting down into the characteristics of post-exertional malaise. Moving on to the exertional part, different sorts of exertion can cause it. So physical, cognitive, it includes stimuli that could be easily tolerated before the illness. So it might be a short walk. It might be reading a few pages. For very severe ME/CFS, it might even just be chewing. Infections, temperature extremes, strong emotions, both positive and negative. For many people with ME/CFS, light, sound, and other sensory stimuli can contribute to an onset. For the severely ill, the threshold can be so low that just the exertion of living means that they're almost always in post-exertional malaise. So we've got a forum member talking about what causes his post-exertional malaise, and there's a picture there of his room.
I spend most of my time in bed or on a sofa next to it. I have a routine which includes some essentials like eating and getting to the toilet, which I can manage okay when not at my worst. But there are many things I need or want to do which go beyond this. Things others consider every day, like basic personal hygiene, a haircut, talking to friends or family, or even just having someone else in the room to clean. And there's bigger or unplanned things, maybe needing to move to another room, organising a new carer, or some other medical issue needing attention, or just thinking about writing and recording this. These are all things where PEM can come in, because they can all trigger it.
So moving on to the malaise part, post-exertional malaise is the preferred term of the members on our forum. Malaise means feeling ill. It's not perfect, a bit like ME/CFS is not a perfect name, but it's probably good enough for now. There's a worsening of symptoms and there can be new symptoms. And function is dramatically reduced. People will often refer to it as a crash. Common symptoms, utter exhaustion, problems with thinking, needing to lie down, and pain. And it's often described as feeling like you've got the flu. And there's a whole host of other symptoms that can come with it. We've got some words here from one of our members, Jonathan Hawkins, about what post-exertional malaise feels like for him.
I experience PEM as a dramatic worsening of my usual ME/CFS symptoms, including exhaustion, flu-like malaise, muscle weakness, and intolerance of light and sound. The only thing that helps me is resting in a dark and quiet room until it passes. Usually this takes days, but can take longer.
So what is it like to have post-exertional malaise? Fred Rossi has been writing about ME/CFS really well, and he's got some words there on what it's like to have post-exertional malaise. I'll just let you read that. The image there, in case the words are too small, the girl on the left-hand side is saying with an annoyed look on her face, "I thought you said you were interesting." And the person on the right-hand side is looking rather sad and clutching a pillow, and he says, "No, I said I was into resting." And the Fred Rossi again, the brutal truth is this: living with post-exertional malaise means making impossible choices every single day. And when the people around you don't understand the calculus you're making, they interpret your careful management of the disabling condition as a character failure. There's currently no good evidence of any cure, and there's currently no good evidence of any effective treatment. There's no evidence for the activating therapies like GET. There's no evidence that they're useful, and some evidence that they can cause harm. Unfortunately, mostly we're left with lying down in a quiet room and waiting for it to pass. In terms of managing post-exertional malaise, it's a trade-off. You can reduce activity, and that will reduce the chance of post-exertional malaise, but it's hard to live. If you don't choose what activity you reduce, then post-exertional malaise will choose for you and probably wipe out everything for some time. One of our members, Dom, says, "The view that you can basically avoid post-exertional malaise and recover if only you planned out your day properly with a diary and some highlighter pens is patronizing nonsense." And unfortunately, we do see a lot of therapists proposing very detailed schedules as if that would somehow motivate us to do more. Life typically doesn't adhere to a carefully planned schedule of 15 minutes rest and then 15 minutes of activity. And the ideas of baseline, threshold, energy envelope imply a lot more certainty than there really is. We've got some words here from Jonathan again about how he prevents post-exertional malaise.
I stop PEM from happening by avoiding exertion which I know will cause it, to the extent that's possible. That means not reading books, not watching television, rarely leaving my bed. With medical care, I must always weigh what poses more risk to my health, the inevitable crash from leaving the house for it or not seeking it at all.
People with ME/CFS naturally learn to pace because getting post-exertional malaise is so brutal. So pacing or activity rationing, which is probably a more accurate term, is actually not about that detailed schedule of activity and rest. It's primarily about making the hard choices about what things are given up. It might be work and the identity and income that comes with that, sport and hobbies, having children, seeing friends, leaving the house, leaving bed. And I chose that picture there of the boy in the bed to remind us that children get post-exertional malaise too, and the decisions that children and their parents have to make about what part of life is hung on to and energy put to, and all of the things that have to be given up. It's quite excruciating. Many people with ME/CFS choose to accept post-exertional malaise in order to achieve something necessary or important, such as applying for financial support or attending a family event. So somebody with moderate ME/CFS wanting to attend a wedding might rest for days. They might attend in a wheelchair so that they don't have to stand and walk. They might leave early, and then they will probably be hit with post-exertional malaise afterwards. People with very severe ME/CFS, they have the toughest choices of all. Do they give up on getting to the bathroom themselves? Do they rely entirely on others for in-bed toileting? Even with 24-hour care, these people might be in post-exertional malaise all of the time, enduring unrelenting suffering in silence and in darkness. I just want to quickly go through what post-exertional malaise is not. It's not post-exertional fatigue. Even the acronym sounds dismissive. People feel ill in post-exertional malaise. It's not just tiredness. It's not fatigability. Typically, post-exertional malaise is not an immediate reaction to exertion. The rapid onset of muscle weakness and cognitive dysfunction, they are part of ME/CFS, but they're not alone post-exertional malaise. It's not the product of deconditioning. It's not delayed onset muscle soreness. It's not a fear-induced retreat from the world. It's not catastrophizing about minor symptoms. It's not hypochondria. And we could do a whole webinar on those ideas. But suffice to say, there's no good evidence for them. And there's no evidence that treatments based on those ideas are helpful. Some people like the term PENE, post-exertional neuroimmune exhaustion. But that term suggests that the cause of the phenomenon is known, and we don't know what causes post-exertional malaise yet. Other people refer to PESE, post-exertional symptom exacerbation. And it's true that symptoms get worse in post-exertional malaise, but symptom worsening after exertion is common in many illnesses. It's just too vague a term. Exercise intolerance. That term is usually used when people with heart or lung conditions or people who are unfit have to stop during exercise. So some things that we want researchers to know. One is that it's really important to be clear what you are talking about. Post-exertional malaise means different things to different people. Do you mean any sort of post-exertion worsening, or do you specifically mean the crash when someone has to lie down? It's important to know that the causes of post-exertional malaise and ME/CFS are not known yet. Have a hypothesis, certainly have a hypothesis, but be careful about the level of certainty. Watch the words you use and question your assumptions. The topic of measuring post-exertional malaise is problematic, and we could do a whole presentation on this. Despite some valiant attempts, there are currently no good direct measures of post-exertional malaise. And that's an unhappy situation for everybody. Patients don't know what to answer when they're faced with questions that are just impossible to answer in any sort of accuracy, or that are irrelevant. We've got some great discussions on the forum about the various post-exertional malaise questionnaires. So if that's a topic that interests you, I really encourage you to have a look. There's questions like, does minimum exercise make you physically tired? Which is not about post-exertional malaise. Post-exertional malaise is variable in severity, delay, symptoms, and duration. And so it's hard to pick a number when you're forced to say, for example, how long post-exertional malaise lasts. And it's really hard to remember what happened. And some questionnaires ask about 6 months. And I struggle to remember what happened last week. And especially if there was some post-exertional malaise there, the days can tend to blur together. It's better to use objective measures of the impact of post-exertional malaise. So time with feet on the floor or daily steps. FunCap is a good measure of reported function, and a daily app to record quality of life. Another thing we want researchers to know is that post-exertion is not the same as post-exertional malaise. Taking biological measurements before and after exercise is good, definitely good. It may give us clues. But if study participants do exercise, they probably don't have post-exertional malaise straight after the exercise. And they may not have it tomorrow if you measure then either, because post-exertional malaise is not delivered to order. Long COVID, some people with a post-COVID condition have post-exertional malaise and ME/CFS, and some do not. Some have other reasons for their health condition. So cohorts need to be carefully selected and stratified. We want you to know about the cumulative cost of exertion. People may seem to tolerate extra exertion for some weeks, but gradually deteriorate. An example from my family, a boy keenly returning to school after a year off with ME/CFS. And after 1 week, everybody's saying, things are great, it's looking really good. After 1 month, the boy himself, if you ask, will say things are great, but he's missing days of school each week. And then after 4 months, sleeping 20 hours a day, only leaving the bed to get to the bathroom. And then it takes many months to return back to the mild ME/CFS level. Some people just don't return to their pre-exertion level. So in an unblinded treatment trial, it's really important to objectively measure function for a long time, well after the enthusiasm, the initial enthusiasm wears off. We want you to know about the hidden cost of people participating in your trials. They may leave your clinic looking fine, but they may have to spend 3 days in bed after that, in pain, not able to make a meal. And it might be more than 3 days, much more. So it really matters how easy you made the process, what directions you gave to people, were they clear enough, how long you keep them sitting in the waiting room. And people with severe ME/CFS won't even get to your clinic. And lastly, we want you to know that understanding post-exertional malaise and ME/CFS is important. There are so many people with lives horribly constrained by post-exertional malaise. So your work as researchers really matters. We really appreciate it when you do a good job, and we thank you when you work with those of us who experience post-exertional malaise to make sure you get things right. So thank you to you all for caring about this topic and being here. I have to give thanks to the fabulous Trish Davis. She's a key member of the Science for ME community, and she led the development of our second fact sheet on post-exertional malaise. Many members contributed to the fact sheet, including members working from their beds. I hope you'll visit our forum to use the resources and contribute to the discussions. Thank you.
Thank you so much, Maree, and thank you as well to Trish and the wider Science for ME Forum for all the work that has gone into this fact sheet. It seems like you were really able to bring in perspectives from people across the range of ME severities and to get to something that describes PEM very accurately. So I hope that this fact sheet will be used widely, including by researchers. So we have a couple of questions. So the first one is from someone who has both lived and professional experience of ME and who's worked in neurology and pain management. And they say that they've observed PEM in people post-stroke as well. And they believe PEM can present in other neurological conditions and sometimes in autoimmune diseases. And they then mention that they think there's an important distinction between PEM and PSE, which is post-exertional symptom exacerbation that you mentioned too. So they're wondering do you have any views on what the difference between PEM and PSE might be, and whether PEM is exclusive to ME or not?
Yes, on the exclusivity, it's quite possible that there are other health conditions where it's experienced. We just don't have good information about that. Sorry, what was the other question?
So I think they were kind of making a distinction between PEM and
post-exertional
PSE.
symptom exacerbation.
Those being two different things, yeah.
Yes, post-exertional symptom exacerbation, as I mentioned, is quite a broad term. So it could be that you hang out the washing and your arms suddenly feel like lead weights from being held up above your head. So in that case, there's exertion and there's symptom exacerbation, but it's not the post-exertional malaise of feeling ill and needing to lie down.
Makes sense. Thank you. So we also have a comment from someone who mentions they have severe ME and are housebound and needing to lie down most of the time. To them, PEM usually has warning signals that come first, but then if they push through those warning signals, the impact usually hits by day 2 or 3. And they find that usually PEM can cause symptoms like speech difficulties, cognitive problems, dizziness, nausea, or tremors. So it's not always physical exertion causing physical symptoms, but it might be cognitive exertion that triggers symptoms that are quite different from the initial type of exertion. So I'm just wondering, does the fact sheet kind of capture the fact that PEM can sometimes involve a trigger and a symptoms that are in quite different systems?
Yeah, that's very true. Both physical exertion and mental exertion can cause the exacerbation of symptoms. And in terms of getting some cues that post-exertional malaise is going to hit, it varies from person to person, and maybe after some years you start to pick up on things. I know that when my legs start to get heavy, when I find it's really hard walking up the stairs, or if I'm talking to someone and I start slurring my words, that's a sure sign that I've overdone it and that I really need to get resting, and that post-exertional malaise might be on the way.
Thank you. And a final question. So there was a comment about the term post-exertional malaise and the fact that maybe for some people, malaise can feel a bit antiquated as a term or might have some sexist overtones that are historically associated with it. Do you have any thoughts on, I know you discussed also other terms and you said PM is probably the preferred term, but any further thoughts on this?
It's certainly not perfect, but malaise is a medical term, meaning being unwell, and it can be applied to a range of serious health conditions, cancer, infections. As I mentioned, I think it's the best we can do for now. People understand what it means, and we don't really have good alternatives.
Yeah. Thank you. So we'll now be moving on to our second talk. So we'll be hearing from Mark Faghy, who's a professor of clinical exercise physiology from the University of Loughborough. So Mark couldn't be with us today, but he's kindly shared a video presentation.
Hi everybody, my name's Mark Faghy and I'm a Professor of Clinical Exercise Physiology from Loughborough University. I'm really sorry that I can't be there today. That is entirely my fault, and I apologise unreservedly to Ed and the team for the mistake that I made in the logistics of being available for today. So I have recorded my presentation in advance, and I would encourage anybody in the audience that wants to reach out or connect or even ask simple questions to use the contact details that I've provided at the end of the talk to do so. Before I start and kind of go into my talk, which is the pathophysiology of post-exertional malaise, what we know, but importantly what we don't, I think it's important to give a bit of a brief introduction to me as a researcher and as an academic. So I'm an exercise physiologist, and in a former life I worked in performance sport, helping athletes to realize their potential using my understanding of physiology and the physiological systems to try and improve performance, and have been very fortunate to work with high profile athletes in various competitions in some really glamorous and some not so glamorous places around the world. My academic specialty is in respiratory physiology, and I've been researching clinically since 2015 with my good friend and clinician Tom Buick, who's at the Royal Derby Hospital. And it was a meeting that we had through the latter stages of my PhD, where he was starting to explore to kind of explore, the physiology of recovery, and said, well, your understanding of physiology, should really help the patients. Surely, if you can identify issues and find ways to make things better, surely that's an opportunity that we should be exploring through clinical research. And to be quite honest, I hadn't ever really thought about that. It wasn't something that I'd remotely thought was even possible, if I'm completely honest. But we've been working together since 2015 on a variety of different projects. Mostly kind of around respiratory infection, chronic respiratory conditions. And that work that we were doing from 2015 to 2020 really led us into kind of the pandemic. And Tom, from a clinical perspective, was on the front line of that. And we utilized our similar philosophy of, the physiology of recovery. What is it that we can do to understand? And that's really important. Part of our research is what do we understand? And from what we understand, what can we do to improve? So that really, in 2020 catapulted us into kind of the acute COVID infection part of the pandemic, and obviously as the kind of the long-term narrative, the long COVID narrative played out, we've been investigating really heavily around the physiology, and essentially our whole research program is underpinned by understanding the limitations of bodily systems. So understanding physiology 101, how does this system work? What's it supposed to achieve? Can we identify where, there might be some limitations there, and what can we do to kind of improve those? And what we were doing, what we have been doing is really kind of looking on a system by system level, looking at the interaction between systems, and to see if we can use that physiologic understanding to understand, the impacts of function, but also on the symptoms that patients experience. And more specifically, I've kind of listed here a few of the areas that we've kind of been working in. But one of the ones that really fascinates us, and one that we're really kind of determined to find answers to, is this mechanisms of post-exertional malaise and fatigue, and we acknowledge that they are two separate symptoms. They're not interrelated, as people may have suggested previously, but what we're trying to do is to understand the kind of mechanisms of what the manifestation is, the pathophysiology is, because we think that if we have an understanding of that kind of mechanistic pathophysiologic insight, that will help us to determine ways in which we can support and find solutions for patients. So I have this title of what is PEM, and the talk that precedes me in the lineup, delivered by Maree from Science for ME, did that excellently. I know that in advance, that will have been covered articulately by Maree, and I think what was really pertinent from the outline of Maree's talk that I've seen is that it's giving that real world and important insights into what it's like to live with PEM. And that is, although I'm a physiologist and I'm driven by the kind of the physiology of systems, the lived experience and the kind of the reality is another really important part of our research. We're big advocates for incorporating and learning from the lived experience within our research. And we've shown that, and when it comes in the context of post-exertional malaise, it's been very prominent throughout all of our lived experience research. As a really key finding, and something that for me gives us context to what we're looking at mechanistically, and where does that become important, because we're not talking in the context of post-exertional malaise about somebody who's run a half marathon or a marathon. That marathon becomes very different, and in the context you can see the example there is went to meet a friend for a coffee, exhausted, needed to rest, and that's the reality. And that's because it's real, and that really does matter. And it's something that researchers really have to understand, and we really understand as a research group, is that we need to bring the reality, the context into the research to make sure that we're asking the right questions, the relevant questions, and the things that, will help us in the understanding. I do just want to take an opportunity to plug this image, and I have to give full credit to Lindsay Skipper, who has been one of our PPI representatives since 2020. We wrote a review paper recently looking at the current pathophysiological understanding of long COVID, and Lindsay wanted to create a tool in which we could help to kind of educate people around what post-exertional malaise is, what the symptoms, the impacts, and where the kind of current understanding is. And I'm not going to go through this step by step because I know that you've already had that insight into what post-exertional malaise is, but it's just a really good, in my opinion, really good tool that Lindsay has developed, to support that. And again, full credit to Lindsay, our PPI rep, for doing that. So, what is PEM? What is PEM? And I've got a few bullet points here, and I'm going to speak very candidly, and I hope that's okay for the audience. I hope you'll appreciate where I'm coming from, by the end of the presentation, and I hope that will really shine a light on the seriousness we place around, working with and valuing the lived experience, and the context that kind of comes with that. So, first and foremost, PEM is real. There's a lot of our lived experience research has shown that, there's a kind of misconception around what PEM is, or, is it a psychological condition? No, it's a pathophysiological condition that is central to and a disabling feature of, both ME/CFS and long COVID. And whilst it's characterised by a disproportionate and delayed exacerbation of symptoms following any form of exertion. And that, again, I know that's been said, but, any form of exertion can kind of lead to that. And it's a really prominent, has a drastic impact on functional status and quality of life. Now, we don't fully know and understand the kind of the causes, and I think there's a lot of research that's happening to try and further that field at the moment. But what we do know is that it's a very distinct and complex biological process, and that sits across multiple systems. And I'll talk a little bit more about that as we kind of progress through the talk. But what I'm really interested and really fascinated in is not having this one system view of what might be contributing to and causing PEM. And one thing I'm really interested as a physiologist is that interconnectedness between the systems and the activity that happens within that connectedness, and how that can also contribute to the bigger, wider presentation of symptoms, but also a post-exertional malaise. I don't think it can be as simple as just, well, there's this here, collectively it shows this. I think, given the dynamic and interacting nature of post-exertional malaise and the physiologic systems, I think there's an overlay that we need to be better in understanding and finding ways to measure and to be able to understand that. Some of the most pertinent mechanisms that are described widely in the literature, and again, I caveat that with there's still a lot of learning to do, and you'll hear me say that phrase several points throughout the presentation, is the immune dysregulation, impaired energy metabolism, autonomic dysfunction, and the kind of the abnormal, not optimal recovery responses, again following any kind of form of exertion. And again, I've kind of alluded to this. It's likely that it's not just one pathology. It's probably going to be multiple pathologies that are interacting, dynamic and flexible in the kind of the presentation that symptoms. But what we do know is that PEM has, really important implications for, rehabilitation and management of chronic conditions, and it's something that we really need to take seriously in, developing research programs and projects that allow us to advance the understanding and allow us to actually inform the development and implementation of appropriate and safe rehabilitation and management strategies. And, I'm very much under the impression when it comes to the concept of rehabilitation that you can't rehabilitate something until you've addressed the underlying causes. And in the context of ME/CFS long COVID, that's going to require pharmacological intervention. I think very much at the moment we're in a position of trying to develop management strategies that allow patients to increase their function and their quality of life, whilst we wait for those pharmacological treatments. And when they then come into play, that's when rehabilitation becomes an opportunity for us to improve that function, in a kind of a longer term phase. But given the undulating episodic nature of PEM, we kind of, we know that we need to kind of manage that as best as we can, but can we actually rehabilitate it? And that's an interesting, provocative, possibly, question that I think, hopefully will create some and stimulate some discussion. And I have to put this kind of final point because it's so prominent and it's such a characteristic feature of our research. We hear it all the time, that failing to recognise or even acknowledge PEM, is more harm than it is positive, and we have to really educate and increase the knowledge and awareness of doing that. And we're certainly championing that through a lot of the research and the research practices that we adopt here in the lab. Everything, we have protocols and safety protocols and mitigation protocols that will try and protect participants that come into our studies, but whilst also trying to learn, because we need to learn to be able to help. I know I'm certainly preaching to the converted with this slide, but I feel I have every opportunity to kind of say it and to say it out loud, because the more people say it out loud, hopefully the message will certainly spread a lot wider. But PEM is not deconditioning or a simple loss of fitness or function. That suggestion has been used for decades. I think it's extremely pertinent that we take the opportunity to reinforce that. We know there is clear empirical academic evidence that shows that it's not deconditioning, and we need to make sure that we kind of champion that. It's also not explained by motivational mood disorders or lack of effort. I've actually just come straight from a meeting having a very similar discussion with one of our PPI representatives who's had a negative experience this week, and just reassuring them that that we are still trying to make sure that we're telling the right messages, and it certainly isn't that. And it's not that typical fatigue response. I've already alluded to the fact that PEM and fatigue are very different components. Whilst some of the presentations around tiredness might seem to overlap, they're very distinct symptoms, and that we shouldn't conflate them to being the same thing. PEM can't be, relieved by rest alone. Pacing and resting is an important constituent of a management strategy for PEM, but it's not predictable. We don't know how long it might take, or in what ways will PEM abate, and it certainly doesn't happen immediately, and it can take, as we know, days, weeks, and even months sometimes to recover from a PEM episode, and we need to be aware of that, and again championing that. And I guess, as it says there, it's not a normal or adaptive response to exertion. We see this disproportionate response to any form of exertion, and I'm going to talk a little bit more about that through the next couple of slides. One of the things that I am really keen to kind of talk about, and I've already talked about the interconnectedness of the physiologic systems and how they work and operate and respond to internal and external stimuli and to physiology on this Thursday afternoon when you'll be watching this. But there's one thing I'm really conscious of is I think we actually need to document and demonstrate this systems level framework for post-exertional malaise. And I think that's important because PEM reflects this kind of multi-system dysfunction. It's not a particular or single pathway or system or process that it is being perturbed and presenting in this way. It's actually much bigger than that, and it's this kind of multi-system dysfunction that we kind of need to be able to evidence and document, that will really help our mechanistic understanding, and the mechanistic understanding will inform, the development or potentially the repurposing of treatments. But again, at the moment, because we don't have that mechanistic understanding, we're not sure where within the systems and the processes can we, input interventions that might help patients. broadly, again, the symptoms are so vast and so differing and episodic as well in patients. And what that suggests, though, is that there's kind of a breakdown in the typical or the usual. I guess I struggle with the word normal because I don't know what that means, but there's a kind of a breakdown in that coordinated regulation across a particular or multiple systems. And I think that the breadth in symptoms and the variety in symptoms that patients will report during episodes of PEM is really reflective of that multi-system interacting pathology that we've kind of referred to. And because we know that exertion is a stressor, and again in healthy normal, we have these regulated adaptive responses. So the external stimuli will be applied, the internal systems will detect that, they will coordinate, and they will regulate a response that is proportional to the external stimuli. However, in PEM, these responses are completely dysregulated and in some cases insufficient, and it's that kind of mismatch between the external stimuli and the response that is characterized well within the PEM. But it says that how can we then improve the body, or understand how the body is regulating certain responses to external stimuli, does have very profound effects on the responses. If there's a chain in the link that is not working appropriately or adjusting accordingly, that has a downstream and even upstream impact on the way that the body is working, and that can promote changes in autonomic control, or we have these chronic immune responses which can stay elevated again for weeks and months and have a real profound effect on how the body responds and it works, but also the perception of how things feel as well. And I'm really interested in this kind of interacting feedback loop of how feedback is received, responded to, and adjusted depending on kind of what's happening. And I think we really want to get to a position of what that might look like. And I've taken this, and I'm not going to spend too long on this because it's a very crazy systems loop diagram which I'm fascinated by, but this isn't for ME/CFS long COVID. This is taken from the area of obesity, but what I've done here is I actually want to show the vast complexity that might be underpinning this, and this hasn't been done for post-exertional malaise, ME/CFS, long COVID. I actually think it should, and if there's anybody in the audience watching this, back that's interested in doing this, then please do reach out, because I think this is a very important piece of work which will help us to map through where, how, when, what, why might be happening, and will possibly give a schematic overview of where we should be targeting thoughts. And again, to my knowledge, and apologies to you all if I'm wrong, I don't think this has been done. I'm certainly not aware of it if it has, and for something I'm interested in, I hope that I would be aware of it. But what I'm really interested in is I think this gives us a really good almost like a bird's eye view of how the different systems might be interacting, and where the opportunities for things to become dysregulated or break down might occur. And I'd certainly be interested in mapping that through with collaborators, and if we could form a project around that, that would be fantastic. I'm not going to talk too much about the implicated pathologies of post-exertional malaise because they're very well articulated in the literature, and that in itself could be a presentation or a whole afternoon, if not a day, because there's so much that we kind of need to talk to about. But what this list does is it actually just articulates again the kind of interacted nature of them, of the pathologies of PEM. So we have, within and between pathologies interacting, providing and demonstrating that kind of PEM response. And I think, again, to go back to the previous slide with that image of the kind of the whole system's feedback causal loops, I think, it's very likely that in patients experiencing post-exertional malaise is that most, if not all, of these will be impacted in some way, but it's the level of severity within each individual system and the connectedness of that to other systems that's the dynamic part, that really then starts to create the challenge in being able to understand the etiology and the mechanistic action, because there is not one consistent pathology from the patients that we've worked with and researched with. There won't be one consistent pathology or pathway of pathologies that will be identical, and I think we have to be okay with understanding that it's going to be really complicated for us to understand how those pathologies or how those systems are impacted, and how that's then contributing to that wider presentation that participants are experiencing. And that makes it really complicated. Probably why we aren't able to advance as fast as we would like to in terms of the research, the understanding, and obviously then the development of interventions to support. And the complexity, again, makes it difficult in terms of people being able to provide answers and support for. But I think what we can do is acknowledge the kind of the complexity, not acknowledge the etiology that's underlying the condition, and use that to find ways and to find solutions. And what that does is it means that we have to think outside the box, and we've been trying to do that with some of our research over the last few years, identify different approaches, being different, stepping outside of our comfort zone, bringing in disciplines that can provide inside knowledge that we don't have within the team, working across boundaries, working with our patients, working with, an open mind will help us identify and make the progress that's required. So the important gaps, this kind of brings us to the bits that we don't know, and the kind of the things that we need to be doing, and to make sure that we're doing things well, and to do things better. I have to put this at the top. Is the forefront of our whole research philosophy is that we work with patients. The patients are the experts of their condition. We take everything to our PPI groups. We don't do anything without their involvement. We don't do anything without their input. They bring questions to us. They keep us relevant, and I think that's really important to making sure that we're answering the questions that are important. But as I've alluded to as well, we also have a number of strategies and protocols to make sure that when we do research, and we are researching to try and advance the understanding, but we're doing it safely, and to make sure that we don't make things worse for patients that's already hard. I think we need to move beyond being reductionist. I think we need to think wider, think bigger, think about this systems biology approach that I've alluded to a number of times. That's something I'm really excited about. I think that will really, really help. We kind of, again, think outside the box. A lot of our research uses kind of submaximal approaches. They're flexible, they're adaptive. They allow us to increase the knowledge and understanding without asking patients to push themselves beyond, safe limits. And that requires a lot of thought, consideration, and, pilot working. But I think that's allowed us to be progressive in understanding the mechanistic understanding. But acknowledging that PEM is episodic, I think we kind of need to make sure that we have these longitudinal designs, and patients will present at an appointment for a research trial, and they will have undoubtedly paced, before they come through. But that doesn't show you the reality of what it's like to live with PEM, for them as an individual. And we need to understand them sometimes, during the height of that, or capture some information during a PEM episode. And that then creates an opportunity for real-time monitoring and technology. Although technology scares me at how fast it's progressing, that actually creates an opportunity for us to do some real-time monitoring in patients, and to learn from patients when they're not in clinical research settings, to make sure that we can, see and demonstrate, how they are away from there. The biomarkers is probably one of the biggest areas that we certainly need, and they need to be reliable and integrated signatures across the different systems. But how can we characterize from a biological perspective, post-exertional malaise? What does that look like in terms of the chronic inflammation, the chronic inflammatory state? How can we, again, use that to our advantage to help and to manage the condition, but also to test targets that will help reduce possibly some of those important areas as well. And I know that research efforts are really intense in that space at the moment, and I'm hopeful that in time we'll have those at our disposal, and that will really accelerate the research that we can do around the development and implementation of those management and treatment strategies. Real world data, again, brings in the technology, leveraging the technology that's at our disposal now, the use of wearables and digital health tools. Continuous monitoring is something I've already alluded to as being incredibly important, and something I think we should be factoring into the design of our studies, and the opportunity to learn, continuously learn, not just in a single time point or in a particular time point, continuously monitoring, observing. And, can we get to a point where we can be proactive as opposed to reactive to episodes of PEM? That would be, transformational. And I think these opportunities together collectively give us that. I also think we need to increase the prioritization of patient-centered measures. Again, this brings back in the context. This brings back in the real lived experience aspect of it. What does it mean to an individual? We're very kind of trained, I guess, to use well-recognized, established outcome measures, and I do understand that, and that's important. I'm not saying that we shouldn't, but we have to think a little bit wider in how the symptoms and quality of life and functional status, what the context is. What does it mean? What does it mean to have a slightly higher functional status? What does it mean to have a slightly better quality of life? Because every patient will have a story and a matter and a meaning to those. And I used the coffee analogy earlier and said that, we're not asking people to run marathons, but for some people going for a coffee is a marathon. And in that sense, we need to be better in terms of capturing the context and the lived experience. So my final thoughts, I'm going to whiz through this, just conscious of time. Just because we can't explain it doesn't mean it isn't real. This is something I use in my lab with the patients all the time, and I find it incredibly validating. And I think we have this kind of notion that, researchers, academics, medics, they must have all of the answers, and quite often we don't. But that doesn't mean that then we can disregard it, and we have to be acknowledging of something. And just again, because we can't explain it doesn't mean it isn't real, or doesn't mean it's not impacting someone. And I feel like we're making progress, but it's certainly not complete, and there's an incredibly long way for us to go to be able to, to give people the answers and to find the answers that people need. I've alluded to this quite a few times. It's a little bit controversial, this one, but we're going to struggle to kind of find these big solutions without having that mechanistic understanding. So we really need to drive research into increasing the mechanistic understanding, and that will allow us to become more focused and targeted on what those treatment and management strategies will be. I think we have a handle, a good understanding, but it's not complete. And I think we need to, that will hopefully drive that forward. No idea why that one's come up first. But yeah, managing PEM is incredibly difficult. It's not constant. It's not a steady state. It is something that's continuously fluctuating and changing. I'm just going to put this here, go back up to those 2 points previously. Treatment and management strategies are going to be incredibly complex when we get to that point, because the etiology is the more difficult a pathology is, the more difficult the complex the strategies are to deal with that. But one thing that is probably a pet peeve of mine is, just because it worked in another condition doesn't mean it's going to work here. Taking things off the shelf and relabeling them or rebadging them, it's not going to cut it. We need to be better than that. We are better than that. And we should be better than that. And most of the people in this space that we're talking to today are better than that. But we certainly need to be thinking about, the novelties and the nuances that of post-exertional malaise and how we can do that. But I know one of the talks that's going to precede me from Todd is going to talk about measuring and managing post-exertional malaise in a lot more detail, which is why I've not gone into it too much today, but I just wanted to give my important thoughts and where my feelings are around on there. And yeah, we've acknowledged that everyone's different and we need those objective measures. And I'm going to take it as another opportunity to plug it, is to probably map this system level framework. I think that will be incredibly important for guiding research moving forward. So yeah, thank you very much to the Prime team for the opportunity to talk today. I'm incredibly grateful to be able to have this opportunity. Big admirer of the work that the Prime Network has been doing. I've been to a number of events previously, and I can only apologise for my own stupidity for why I'm not doing this live. I've talked about that at the start, and I do again extend my apologies to the Prime team. And again, that's my fault entirely. But what I will finish with is just by saying we're an extremely collaborative group. We have philosophies and shared vision to find ways to help people. And I'd encourage anybody who's, if anything I've said has struck a chord, or is there any interest to have conversations and follow up, then please do via my email that's at the bottom of the screen. And I thank you very much and wish you a good rest of the afternoon. Thank you.
So thank you to Mark for that video presentation. Really an important overview of the pathophysiology of PEM, what we know and what we still don't. So as mentioned, if you have any questions for Mark, please reach out to him using the email address that we've put in the chat. I also want to thank those who are adding comments in the chat, for example, about your lived experience of PEM. We'll make sure to capture this in the notes from the webinar and share this with the speakers and also with the Prime Network. So now I would like to introduce our next speaker, Marjon Wormgoor, who's an independent researcher and MECFS research advocate. So Marjon will be talking about how post-exertional malaise has been insufficiently captured or overlooked or misinterpreted in clinical trials. So over to you, Marjon.
Thank you. You hear me now?
Yeah.
Okay. Thank you for this introduction. I'd like to discuss today how inadequate capture of PEM may affect intervention research in ME and long COVID. I'll focus on how this may influence the validity and the safety and interpretation of intervention studies. I just have to try to continue. Yes. PEM has been recognized as a key feature of ME for more than 2 decades, and it also affects a substantial subgroup of people with long COVID, as we know. Yet, many intervention studies still do not adequately identify, assess, or interpret PEM. I'll first explain why this matters and then discuss the key methodology.
Sorry to interrupt, Marjon. Do you have slides that you're sharing?
Yes.
Okay.
Then
we can't see them at the moment.
Okay, at the one moment, please. That's strange. I try once more. You see now?
Yeah, we see. Yeah.
Okay.
Thank you.
Then you can have a quick read. Yes, next slide. Although different diagnostic criteria use different terminology, they describe the same core phenomenon and this appropriate, often delayed and prolonged worsening of symptoms following exertion. This makes PEM fundamentally different from ordinary exertion responses. These characteristics are familiar to you, so I won't go through them again. But they differ in symptom pattern, trigger-response relationship, and time course. Disease severity also influence how PEM is expressed. Taken together, these distinctive special characteristics of PEM make it difficult to capture PEM using conventional research methods. I will come back to this. This raises an important question. What do we actually mean when we say that someone has PEM? I find it useful to distinguish between two related but distinct concepts, PEM susceptibility and PEM manifestations. PEM susceptibility refers to the underlying tendency to develop PEM when exertion exceeds the individual's threshold, and PEM manifestations are the actual episodes of symptom worsening that occur after exertion. If someone experiences PEM, we can assume that underlying susceptibility is present, but the opposite is not necessarily true. A person may remain susceptible while avoiding PEM through pacing and restriction of exertional load. This distinction is conceptual rather than diagnostic, but I find it useful because it helps, at least me, explain several methodological challenges. So why is PEM so difficult to assess? There are two main reasons. First, the underlying PEM susceptibility cannot be measured directly. We still lack both a reference standard and a clinically applicable biomarker, as mentioned earlier today. In addition, susceptibility is often confused with PEM manifestations. Second, PEM manifestations are difficult to capture because they are delayed and cumulative, multisystemic, and vary with the type and intensity of the trigger and individually. As a result, assessment of both PEM susceptibility and PEM manifestations currently relies on indirect indicators such as characteristic symptom patterns, functional consequences, and their delayed relationship to exertion. Intervention studies are based on several methodological assumptions. These assumptions are generally reasonable, but they may not hold in the presence of PEM. For example, we usually assume that the appropriate participants are included, that the defining clinic feature is correctly identified, and that participants start from a reasonably stable baseline. According to outcome assessment, we usually assume that the core features of the condition are adequately captured by outcome measures that are valid and responsive, and that they are assessed at appropriate time points. Finally, we generally expect interventions to produce benefit rather than worsening. We also think that average short-term effects and routine safety assessments provide an accurate picture of benefits and harms. And furthermore, intervention dose is assumed to be related to the response, even so are effects expected in the same domain as the exertion. PEM may challenge several conventional assumptions underlying intervention studies. Over the next few slides, I'll show how it affects each of these assumptions. The first assumption concerns study population validity. Does the study population actually represent the population we want to study or to treat? In ME, this may be achieved by using diagnostic criteria that require PEM. If broader diagnostic criteria are used or participants are recruited based on routine clinical diagnosis alone, PEM susceptibility should be very wide. In long COVID, there is currently no PEM-sensitive diagnostic framework. Assessment of PEM susceptibility is therefore essential, yet it is often absent or insufficient. Representativeness is also affected by self-selection and disease severity. People expecting symptom worsening may be less likely to participate, and most studies include, therefore, predominantly mild or moderately affected participants, while those with severe disease are rarely represented. Taken together, failure to adequately identify PEM may compromise study population validity and limited the applicability of study findings to people with PEM. In ME, the diagnostic criteria used to identify participants largely determine whether the study population reflects the intended population. This figure shows how the role of PEM differs across case definitions. Broader criteria, such as Oxford and Fukuda, here in red and blue, may include people with PEM, but they do not identify who those individuals are. So, case definitions influence the likelihood that the in contrast, I want to say more recent ME criteria, here below that yellow line, define a narrower patient population by requiring PEM as a key feature. So, case definitions influence the likelihood that the study population represents people with PEM. Consequently, findings from broadly defined fatigue populations cannot automatically be assumed to apply to PEM populations. This raises an important question. How have these different case definitions actually been used in randomized intervention trials? This overview summarizes the diagnostic criteria used in 16 CBT and 17 activity-based randomized intervention trials published over the last 25 years. Only one study required PEM as an inclusion criterion for all participants. So, for almost all of the current evidence, we don't know which individual participants had PEM. This current intervention evidence has uncertain applicability to people with PEM. If diagnostic criteria alone are insufficient, the next question is how we can identify PEM susceptibility reliably. A valid assessment needs to meet two methodological requirements. First, it needs to be sufficiently sensitive. It should not rely solely on experienced PEM manifestations, as these may be absent because of pacing or trigger avoidance. Second, it must be sufficiently specific. It should capture the characteristic features of PEM and distinguish it from other exertion-related fatigue and symptom worsening. In other words, PEM assessment should identify underlying susceptibility while distinguishing PEM from other exertional responses. Otherwise, we risk both false negative and false positives. Several methods are currently available, but none captures all aspects of PEM, I think. The DSQ questionnaires are currently the most widely used self-report instruments. The shorter versions place greater emphasis on exertion-related fatigue and fatigability, whereas the longer versions assess a broader range of characteristic PEM features and may improve sensitivity and specificity. The shorter versions include proposed classification criteria, although these may favor sensitivity over specificity. For the longer versions, appropriate classification criteria remain unclear as far as I know. FunCap, mentioned before, was not developed specifically as a PEM instrument, but because it assessed the consequences of activity, it may provide indirect information about underlying PEM susceptibility, even when current PEM manifestations are absent. Other approaches, such as diaries, wearable monitoring, and CPET, capture different but complementary aspects of PEM. However, none has been established for identifying underlying PEM susceptibility. Taken together, current methods capture complementary aspects of PEM, but no single instrument has been established as optimal for identifying underlying PEM susceptibility. The choice of assessment methods should also be guided by the research objective. If the aim is disease management, the relevant outcome is reduced PEM burden, for example, less frequent, less severe, or shorter PEM episodes. These improvements may result from pacing or symptom management, without changing the underlying susceptibility. If the aim is disease modification, the relevant outcome is change in underlying PEM susceptibility. Potential indicators include a higher exertional threshold, a reduced response to comparable exertion, faster recovery, or sustained improvement across activity levels. However, no intervention has yet been shown to reduce underlying PEM susceptibility, as I know. So, the intervention aim should determine which outcomes are assessed. Disease management and disease modification require different outcome measures, otherwise we risk evaluating an intervention against a wrong outcome. We also need to consider when and how PEM should be assessed throughout the intervention process. Assessments begins at baseline by identifying PEM susceptibility and current manifestations. During the intervention, repeated assessments should monitor changes in PEM manifestations, detect symptom and functional worsening, and identify possible PEM-related withdrawal. Immediately after the intervention, assessment should capture delayed PEM. And at follow-up, PEM should be reassessed over the same time window and baseline to evaluate the recovery duration. Persistent or recurrent PEM manifestations, changes in activity and function, and where relevant, changes in underlying PEM susceptibility. PEM assessment should therefore extend throughout the intervention process rather than being limited to a single endpoint. For disease-modifying interventions, changes in underlying PEM susceptibility should also be evaluated. Current evidence of activity-based interventions in RCTs. What do they show now? This figure summarizes the randomized controlled trials of activity-based interventions according to diagnostic specificity. Green represents benefit and orange no effect of the interventions. As you see, most evidence comes from studies using broad diagnostic criteria, the blue and the red ones, and relies mainly on subjective outcomes. Objective outcomes were included less often and generally showed little or no benefit, and relatively few studies included longer-term follow-up. Taken together, evidence for benefit appears less convincing as diagnostic specificity increases, objective outcomes are considered, and follow-up becomes longer. As most evidence for activity-based intervention is based on subjective outcomes only, the obvious question is how these findings should be interpreted. When subjective improvement is reported, there are several possible explanations. Some reflect genuine intervention effects, such as improved symptom management or reduced PEM manifestations. Subjective improvement may also reflect non-specific influence, such as therapeutic reframing, response shift, or expectancy effects. In people with PEM, feeling better does not necessarily mean being able to do more. Symptoms may improve because activity has been reduced to avoid triggering PEM, rather than because the underlying disease has improved. Likewise, fewer PEM episodes do not necessarily mean that the underlying susceptibility to PEM has changed. Subjective improvement should therefore not be interpreted in isolation. Without complementary objective measures, it may be difficult to determine whether they represent clinically meaningful changes in PEM. This raises another methodological issue. Do the instruments commonly used in ME or long COVID studies actually capture clinically meaningful changes in PEM? There are two main methodological challenges. The first challenge is construct validity. whether an instrument measures what we actually want to measure. For example, the SF36 physical functioning scale measures physical functioning, but not the post-exertional consequences of activity that are characteristics of PEM. FunCap, in contrast, was developed specifically to capture those consequences. The second main challenge is responsiveness, whether an instrument can detect clinically meaningful change. Broad response categories and floor or ceiling effects have been reported for commonly used questionnaires, for instance the Chalder Fatigue Scale and the CIS Fatigue Severity Subscale. As a result, these limitations may mask worsening, particularly in more severely affected patients. The key point is that commonly used outcome measures may not adequately capture PEM or clinically meaningful changes in PEM. PEM may also influence the validity of psychological outcome measures frequently used in ME and long COVID research. Symptoms may be misattributed. Somatic items in questionnaires, such as the depression inventory, may reflect core ME symptoms. Worsening during PEM may be interpreted as increased depression rather than PEM. The second issue is behavior misinterpretation. Reduced activity, as measured, for example, by the Tampa scale of kinesiophobia, may reflect an appropriate pacing strategy to prevent PEM rather than maladaptive fear avoidance. The third issue is illness perception. Questionnaires, such as the Brief Illness Perception Questionnaire, cannot distinguish realistic illness appraisals from maladaptive illness beliefs. The key point is that PEM may compromise the validity of some commonly used psychological measures because questionnaire responses may reflect PEM-related symptoms and responses rather than the psychological constructs that they are intended to measure. Besides efficacy, we also need to ask whether intervention-related harm is adequately captured. The first challenge is adverse event assessment. Routine short monitoring may miss delayed or prolonged PEM, and standard adverse event reporting is not designed to capture its characteristic features. The second challenge is safety monitoring. Many studies do not include PEM-specific deterioration criteria or incorporate PEM-related worsening into stopping or withdrawal criteria. Finally, withdrawal itself may be an important safety signal. Participants experiencing PEM-related worsening may be more likely to withdraw, yet the reasons are not often reported. They are poorly reported. So, failure to capture intervention-related worsening may leave clinically important harm undetected. Even when deterioration or withdrawal is recognized, the way data are analyzed and reported can still influence the conclusions. First, how treatment effects are summarized matters. Average treatment effects may mask the clinically meaningful worsening of participants with PEM. Similarly, dichotomized outcomes may mask both improvement and worsening within the same population. Second, missing data require careful consideration. PEM-related worsening may increase dropout, resulting in differential attrition between study groups. Standard methods for handling missing data may then underestimate harm and overestimate benefit. Finally, reporting results also matter. Positive short findings may receive greater emphasis than longer-term follow-up, while objective outcomes may receive less attention when they do not support subjective findings. So, failure to account for PEM in analysis and reporting may overestimate benefit and underestimate harm. We've now discussed several methodological challenges. The question is what they mean for interpreting the evidence. Several common assumptions may not hold for people with PEM. Common misinterpretations. Findings from broad fatigue populations are often generalized to PEM populations, although we frequently don't know whether participants actually had PEM. Subjective improvement may be interpreted as disease modification despite limited objective evidence. Likewise, short-term improvements may be assumed to persist over longer time periods. Further, average treatment effects may be assumed to apply equally to all patients, and failure to detect harm may be interpreted as evidence of safety. The key message is here that the applicability of intervention findings depends on how adequately PEM has been identified, assessed, monitored, and analyzed and reported. These considerations have implications not only for future study design, but also for how we interpret the existing evidence. Across the entire trial process, from participant selection to reporting, PEM should be explicitly considered rather than treated as an ordinary fatigue response. First, study populations should be characterized with respect to PEM susceptibility, and potential PEM-related harm should be considered from the planning stage onwards. Second, outcome assessment should distinguish PEM susceptibility from PEM manifestations and capture clinically meaningful changes in symptoms, function, and activity. It should also account for delayed effects and, where feasible, include complementary objective measures. The next, safety monitoring should explicitly capture PEM-related deterioration and consider PEM-related withdrawal as an important safety signal. Finally, statistical analysis should account for worsening, for attrition and missing data related to PEM, and stratify by PEM where appropriate. Because PEM differs fundamentally from ordinary fatigue responses, intervention research requires a PEM-sensitive methodological approach to improve the validity, safety, and clinical relevance of the evidence. So, to conclusions and key messages. To conclude, PEM challenges several key methodological assumptions underlying intervention research. Generating valid and clinically meaningful evidence therefore requires a PEM-sensitive methodological approach throughout the whole trial process. Overall, most intervention studies in ME and PEM-related long COVID have not adequately addressed either the identification of PEM susceptibility or the evaluation of intervention effects on PEM over time. As a result, the current evidence provides only limited guidance on the efficacy, safety, and clinical relevance of interventions for people with PEM. And my concluding message is simple. Adequately capturing PEM is fundamental to valid, safe, and clinically meaningful intervention results in PEM and ME and PEM-related long COVID. So it's time to face with PEM head on. Thank you.
Thank you very much, Marjon. A very interesting talk and very thought-provoking. Unfortunately, we're out of time for questions, but if there's a way that people can get in touch with comments and questions, then feel free to add that information in the chat, Marjon.
Yeah, I can share my email.
And any information also about your work in general, and we'll make sure as well to share this through the Prime network.
Yes.
So we'll now be taking a 15-minute break, and so we'll be back at 3:50 p.m. UK time. See you shortly, everyone.
Okay, so welcome back, everybody. We're a little bit early, but just make sure that you can hear me. Daphne, if you can't hear me, put a message in the chat. So I'm Carl Morton from the University of Oxford. We've been working in MECFS for the last 8 or 9 years, looking at the biology, and I'm going to chair the next session and introduce the speakers. So it's a great privilege to be able to introduce our next 2 speakers who have really been leading the way in pushing the science forward in this really complex disorders has been discussed earlier. So the first speaker will be Todd Davenport from the University of Pacific and give the first of the talks. So Todd's work in trying to understand the exercise response in MECFS has been really crucial in building up our knowledge of the biological processes which underlie this condition. And then the second speaker is Maureen Hanson, University of Cornell. She's an experienced molecular biologist who over the last 17 years is probably one of the longest standing researchers in the field, has really been pushing this forward at the biological level. And Maureen's work has been pivotal in really showing that this illness really has an underlying biological basis. So with no further ado, Todd, I'll hand over to you to give your presentation. We'll take questions at the end if there's time, so please put your questions in the chat. So Todd, over to you.
Thank you. I really appreciate the kind introduction, and thank you for holding this space for me. It's a privilege to be on the virtual stage with this group of luminaries in our field, ranging from patients with lived experience to experienced researchers who, as Carl mentioned, are really working to push things forward. So again, thank you so much. My talk hopefully will complement a lot of what we've heard so far in this webinar. Hopefully not totally repeat, but hopefully some of that repetition you'll find helpful and comforting that people are having some similar thoughts. I'm going to be leaning into my identity as a clinician scholar. I'm a physical therapist and an exercise scientist, and have been very interested in the systems level physiology of MECFS for about the past 15 years. And so we'll be talking a little bit about the relevance of post-exertional malaise to both scientific and clinical approaches. And I'll apologize for mixing metaphors here. We're talking about the elephant in the room. The elephant in the room is post-exertional malaise. The elephant may be in the clinical room. It may be in the research lab, but nevertheless, post-exertional malaise is the key issue to deal with, I think, in ME. And how to eat that elephant really comes from an aphorism that's widely attributed to Archbishop Desmond Tutu, which is how to eat an elephant one bite at a time. So trying to unpack these scientific and clinical approaches in a stepwise manner. In 20 minutes is a challenge, but I will go over hopefully some key concepts that are helpful. And there are some challenges of naming and characterizing this elephant in the room. And this goes back to an old Indian parable of, in this case, blindfolded scientists. This is the adaptation, trying to characterize the elephant based on their own experience with the elephant. So, the scientist at the tusk, poking on the tip of the tusk, insists that it's the spear. The one palpating the trunk insists it's a snake. The one on the step ladder, feeling the side of the elephant, insists that it's a wall. And so post-exertional malaise, being a multi-system, multi-symptom phenomenon, really hits us in a weak spot as humans sort of administering imperfect human processes in science and in clinical practice, that we are siloed by nature and by necessity, can't know everything. And so the studies that come out necessarily will reveal piecemeal bits of information that we then need to sort of put together. So as someone who's interested in systems and system interactions, obviously trying to maintain a focus on the big picture has been something that we've strived to do, but it is difficult to do that. In addition, you could add a couple of scholars on the side there that doubt the existence of the elephant. So these are folks that don't believe post-exertional malaise exists, that believe that this is a psychosomatic condition, which obviously is completely counter to the extant data that we have related to physiological response and lived experience. But we could add to this parable and this roster that you see on the screen. So again, challenges of naming and characterizing the elephant really relate to the experiences that come from our clinical and research silos, as well as the folks that are not pictured, who don't believe it exists anyway. So I'm going to start with my premise, which is that determining the presence of PEM is the key research and clinical decision point. So the challenge of spotting the elephant in the room is that the elephant frequently hides, and it hides in and among other diagnosable conditions. It hides in and among sort of other kind of this diverse presentation. It also hides in terms of a often slow spiral, where the very mild cases are not immediately detectable, both in research and clinical practice, and maybe even to the person themselves. They person themselves may initially feel that something is wrong, can't put a finger on it. Can't tell you how many times I've heard the story of, I got sick with an infection, and just got back to about 60, 70, 80%, decided that I didn't want to live like that anymore, really needed to get back into exercising, and so went for a vigorous walk, another bout of vigorous exercise, and ended up having that first sort of recognizable flare of post-exertional malaise. So again, determining the presence of PEM is really the key decision point, because it informs so much of the subsequent actions that come next. This is still one of my favorite studies because it's a nice visual depiction of post-exertional malaise. This was done by Van Ness and colleagues in 2010. My colleague Mark Van Ness at the Workwell Foundation, and what they did was they did exercise, maximal cardiopulmonary exercise tests in 25 women with ME/CFS and 23 age-matched sedentary women. And they did some mixed methods research to identify signs and symptoms. So immediately after, they gave everyone a questionnaire 24 hours later and 1 week later, and you could write down as much or as little as they wanted. And what they found were at the top bar graph there in the foreground is the immediately following. The middle bar, set of bars, is the next day, and then the beyond is the farthest away, sort of on that Z axis. And so what you notice is that everyone was tired, everyone had muscle and joint pain, people were nauseous, maybe had a bit of a headache, weakness and instability, but by the next day they were fine, and by 1 week beyond, it was like nothing had ever happened. Could not be further from the case in the folks with ME. Not only did we see significant fatigue post-exertionally, but we also saw a whole host of signs and symptoms that we did not see in people who were controls. And we, in the next day, in many cases, in some cases, I should say, these even got worse. Muscle and joint pain got worse. Cognitive dysfunction, which we did not see at all in people who were sedentary, we saw with ME, and that amplified over time. We also saw sore throat, swollen glands. So this goes back to some of the comments from speakers that this is a real illness that people are experiencing. So again, the whole range of signs and symptoms should give us a good clinical indication that post-exertional malaise may be happening. Just in the way of some definitions, of course, PEM is what everyone calls it. It's the familiar name. It's often preferred by people with lived experience, but not universally so. It's probably most specifically characterized as post-exertional neuroimmune exhaustion in the international consensus criteria. It is a compulsory aspect of the diagnosis of ME, and I've highlighted it on the left, but I'll go ahead and just go through it. The PENE is characterized by a marked rapid physical and cognitive fatigability in response to exertion. People tend to get used up quickly. Post-exertional symptom exacerbation, which we've heard about, is a feature, meaning that the symptoms do get worse after an exertion. This exertion can be physical, cognitive, emotional, environmental, and others. Post-exertional exhaustion may be immediate in some aspects, but is frequently delayed, and the recovery period is much longer than one might expect. And as I mentioned, another key characteristic clinically and in research to really watch for is a low threshold of physical and mental fatigability, which we might characterize as a lack of stamina, that tends to decrease over time. So there's this spiraling cycle of decline of function and increasing symptoms, and that results in a substantial reduction in pre-illness activity level. And I'll point out that the descriptors of mild, moderate, and severe are not linear. Mild starts at 50% of pre-illness function. And so I would not consider that to be in any other condition. I would not consider that mild. So just to achieve the moniker, the description of mild, you have to have significant functional impairment. And as been mentioned, there's been an increasing centrality of post-exertional malaise to identify ME, so that contemporary case definition criteria require post-exertional malaise, starting with the Canadian consensus criteria, so that there's this increased specificity for exertional intolerance that we would characterize as ME, as abnormal, as being a kind of a coherent clinical presentation. Very nice study came out in 2023 comparing these case definition criteria based on an online survey of participants filling out the DePaul Symptom Questionnaire version 2. And in the periphery, you can see the Fukuda criteria. Fukuda criteria are PEM optional. And so it's kind of the largest circle. The most participants met those criteria. And then the most exclusive criteria were the international consensus criteria, which I just had up on the screen. And so this was replicated across two different samples, both a Netherlands-based sample and a US-based sample. So really, as we've gone over time, we've refined these case definition criteria in order to identify an increasingly select and coherent group of sort of clinical presentation, indicative of extreme kind of sort of loss of function, intolerance to exertion, yes, but delayed recovery as well. However, these case definitions in ME research have not been, these more specific case definitions in ME research have not been as widely applied as those that are less specific. And so again, I think Marjon did a really nice job of kind of going over the importance of case definition specificity, just as important in the clinic, because not only do these case definitions predict who is diagnosed, but also what we can learn in research about the diagnosis. So if we think about the broad universe of signs and symptoms after an exertion, which we might call post-exertional symptom exacerbation. Again, post-exertional malaise is one subset of post-exertional symptom exacerbation. So I don't think we can think of these things as being synonymous, even though there has been sort of a movement among some individuals with ME and also outside of ME to sort of conflate PEM with PESE and assume that PEM may be present in other conditions, which is an issue I'll unpack in a moment. But post-exertional malaise is maybe considered a subset of PESE. And then within that, probably the best, most specific characterization of PEM that we have in terms of the consensus is PENE. And then within PENE, just to add confusion, is PESE again. So again, hopefully this kind of visual depiction gives a sense of the interplay between the various terms, and hopefully will help kind of clarify those moving forward. Obviously, in clinical practice and research, defining and coming to consensus on terms is critical, but the overall idea here is that an exertion is a trigger in an energy limiting illness like ME. where it takes energy to maintain homeostasis. And so post-exertional malaise really reflects a failure to accommodate that exertional load, whether it's balancing your checkbook, trying to put up with the light coming through the shades in your bedroom, or other types of exertions. So, why organize our research and practice around ME? Well, it begins to correct an entire history of epistemic injustice, bias, and gaslighting. It ensures that we're adequately addressing the needs of lived experience and also developing and implementing PEM-compatible research and clinical practice to improve inclusion. So again, this is another reason why PEM should be central in our consideration in the clinic and in research. So how to find it? It's very common to use questionnaire data. These are recommendations from the National Institutes of Health Common Data Elements Working Group for ME/CFS. The core PEM assessment questionnaires, the DSQ PEM, and then also the second step is a confirmation, clinician's own evaluation, review of medical records, other patient-reported scales, and results of other testing. Here is the DePaul symptom questionnaire, which has been sort of talked about a little bit. It requires at least moderate impairment half the time in 2 items of the 5 that you see at the top of the screen, as well as answering supplemental questions. These supplemental questions are supposed to be more specific for PEM, which include yes to either worsening of fatigue or energy-related illness after engaging in minimal physical or mental effort, and then a response of more than 14 hours of recovery time. But as a screening tool, it's not perfect. It's a very good start to the conversation. It's an excellent first step. But many research studies, many clinics are using it as the sole inclusion criteria. The problem with that is that just including based on physical and mental exacerbation does not distinguish very well between people with ME and people with other fatiguing health conditions. And so this comes to a lot of the confusion related to people thinking they have PEM because they have physical exacerbation or they have mental exacerbation. Where a lot of the specificity comes in is at the bottom of the screen in terms of the recovery time. Again, perhaps reflecting post-exertional malaise as an phenomenon of impaired recovery. However, the recovery period of 24 hours or more tends to exclude more people with ME than a recovery period that's shorter. So that's interesting that folks maybe on the milder side of the spectrum of people with ME might actually be excluded with more rigorous recovery criteria. So just something to kind of keep in mind there. Now, in the way of the current guidance from the US CDC, the US NIH, there is baseline testing. This is inconsistently adhered to, obviously, among health systems across the world, as well as clinical practices even here in the US. But a whole host of different blood tests for oxygen carrying capacity, for inflammation, renal liver function testing, thyroid tests, iron studies, screening for celiac disease, and additional tests that are guided by clinical suspicion. And that's because we're trying to identify pertinent rule outs that they call, but I would say considerations, because again, ME may lay over or may be accompanied by diagnosable health conditions. And so these are the various different types of rule outs that are published in the NIH and CDC. Obviously, the psychiatric conditions are on the list, but should be considered last and certainly not considered causative. And just to make the point that ME is not an either or disease, it's a both and disease. And so if we're looking for the most parsimonious explanation of a condition based on William of Ockham, we're going to be disappointed. And so John Hickam and Hickham's dictum seems to win the day here, where a patient can have as many diagnoses as they darn well please. Again, ME may occur in the setting of other diagnosable health conditions. Addressing those conditions in a way that is sensitive to ME can help improve quality of life, and this forms the basic philosophy for supportive management. And again, as has been mentioned, there's no cure for ME. Often in the research and in clinical practice, you see a scattershot of different signs, symptoms, and diagnosable conditions being considered on the left of the screen. But if we consider post-exertional malaise to be central, then we're trying to identify those features which vary based on exertion. And that tends to be, again, a very key clinical decision point, and definitely not only a way to identify cause and effect relationships, but also potentially identifying how to measure and how to promote meaningful change in these signs and symptoms based on the level of exertion and recovery time afterwards that a person can tolerate. And so I just want to close by reflecting on some of these subgroup approaches, because one of the themes that's emerged in the literature and in the clinic is really sort of thinking about some of these diagnosable health conditions, these signs and symptoms, these bites of the elephant, if you will, as the elephants themselves, or being representative of the elephant themselves. And so I'm going to use the example of a tree. Obviously, this is a figure of an oak tree on your screen. We're standing at a distance. We can see the trunk. We can see the leaves. We can see that this is an oak tree. But frequently, when we see people in the clinic, we're looking at the top of the tree. We're taking a bird's eye view of a pathophysiological cascade that's already occurring. It's already in motion. And so if we look, it's much harder to get a coherent picture of what's going on in the structure of the tree. And we might be tempted to think that the different branches and the boughs of the tree are different trees. They're different subgroups. And if we look at this cross-sectionally, again, we might be tempted to think that the branches and the leaves are different entities. And of course, this tree is by itself, but this tree is also occurring perhaps in the setting of other trees. And so different leaves, and we might see the different leaves interacting with the leaves of the tree that we're looking at. And so cross-sectionally, we might be tempted to think that these are all different entities. And this is the same as our cluster analysis, actually, that we see in the literature, in terms of subgrouping being all about perspective and being sensitive to the characteristics of specific samples, and characteristics of the kind of the diagnosable conditions that people may carry. And going back to our initial analogy of really sort of thinking of these subgroups as instead of thinking about the whole elephant, we think that there's a spear subgroup, and that there's a fan subgroup, and that there's a rope subgroup, and that they all must be different entities. So that's what I had for you. I appreciate your time, your attention. Thank you for sticking it through for this long in the session, and I would love to entertain any questions or cogitation. Thank you.
Great, thank you, Todd, for an excellent presentation. So if you've got any questions, just write them in the chat. Maybe I'll kick off with more of a concern, Todd. So we've been doing mainly work on other people's samples for a long time. We're just about to start some intervention studies of our own, using approaches that we think could improve patient symptoms, even in the short term. Yes, we can do questionnaires to assess PEM, but what we're doing could also help somebody with depression. So how do we make sure that somebody that comes into our study, even though they might fill in the questionnaire saying they've got PEM, is there any way that you've seen in your clinical work that might give us some clues if we've got somebody that wants to come in that doesn't really have ME, coming into our, because we're always running very small studies. And so if we've got 20 patients going through intervention, we don't really want 3 or 4 that have something different because we haven't been able to exclude them. I wonder whether you've come across that or a way of separating people out.
Yeah, that's the million-dollar question, and thanks for your work in this space. Obviously the intervention studies are critical, and very difficult to get right because of the selection criteria. My sense is, as much as possible, adhering to that 2-step approach of using the initial screening questionnaire, but thinking about that as the start of a conversation instead of the gold standard, and then including a clinician, a knowledgeable clinician in the area of ME can be helpful with those pertinent rule outs. So, I've worked with plenty of people with depression as a physical therapist. And there's some very, very stark differences between people with depression and people with ME. The people with ME want to do things. Their lives are completely different They're in many cases severely impacted and even ruined. People with depression have a hard time getting to the point of doing things. And so it's a very different clinical presentation. And so I think having a clinician who can help sort through those and really kind of make sure that those pertinent considerations are being made is very helpful.
Great, thank you. Let me just check the chat. Maybe a final thing, Todd. So what's the next step for you in terms of your research? Have you got something that you're working on at the moment or a long-term goal with your work?
Yeah, a couple of things that we're working on. We're trying to do some cellular work in the way of understanding the response of the body during PEM to metabolism. Looking into some different metabolic pathways that may affect oxidative phosphorylation. So we're very excited about that. Also involved with on the very sort of the very periphery of some clinical trials work, trying to consult on these issues of patient selection criteria. So plenty to be excited about in this space. And yeah, thank you.
Great. No, thank you. Great. So thank you, Todd. I think we'll move on to Maureen Hanson still. Maureen, are you still there?
Yes, I'm here.
Great. Yeah, if you'd like to share your slides, you've probably got a few more minutes. Yeah, they're coming. It's always a good sign. See the screen change. Brilliant. Yeah, over to you, Maureen, whenever you're ready. Just go ahead.
Okay. All right. So I'm going to be talking about our molecular work on post-exertional malaise. And I have pictured here the 5 people whose analyses I will be talking about. Okay, so I got interested in using an exercise challenge because it allows you to compare the same person in 2 different states. So if you have someone who has ME/CFS, they're already bad, and after exercise, they've gotten worse and are experiencing post-exertional malaise. While a healthy person after exercise may have some symptoms of, for example, muscle soreness, but they're not going to be having post-exertional malaise. And we'll be able to compare then the difference between the healthy people before and after their exercise, and then the ME people before and after exercise. And of course, also compare the healthy at baseline and after the exercise. So in our Cornell Center study, we used only participants who became ill before 2020. So these are not long COVID patients. These are people who became ill before 2020. We collected blood at 4 different times. So we called D1 pre, that's day 1 before the exercise. Then post day 1 is after the exercise, we collected blood. And then after 24 hours, the participants came back and did a second exercise. We collected their blood. What we call this D2 pre, and then we have D2 post. And we had 91 patients kindly volunteering to do this, despite knowing it was going to induce post-exertional malaise. We had 82 sedentary controls. And in doing this, a key parameter that exercise physiologists will tell you about is the VO2 max, which is the maximum oxygen consumption that someone who's doing this exercise utilizes. And so this is related to your fitness, your age, and your sex, with males usually having higher VO2 max, younger people with higher, and younger people and more fit people having a higher VO2 max. So we wanted to be able to compare our data with ME/CFS cases who are largely sedentary. So we required the controls to be sedentary as well. And we did pretty well. If we look at the VO2 max of the controls here and compare it to the patients, it's pretty comparable, although we did have these 3 controls who may have been a little more fit than we had hoped for. But in general, the controls were pretty close to the patients. They were actually rather sedentary. I think this is important to interpret results, because if you have a lot of difference in the fitness of the controls versus the patients, some of your differences can be due to fitness rather than to the illness. And to give you an example, the controls used in the NIH intramural study were not sedentary. The colors here are reversed. So this is the controls. You can see their VO2 max is considerably higher than most of the patients. There was only one patient who had a good VO2 max. So some of the differences that they saw could easily have been due to the different levels of fitness. A maximal CPET is certainly not necessary to cause PEM. As we heard from Maree in the first talk, it's certainly going to be predicted to be a strong inducer of PEM. But as she pointed out, for some people, just meeting with friends socially can induce PEM. And almost anything can induce PEM if you're a very severe patient. So what we're doing to people in having them do the 2-day CPET is really a very strong inducer. And whether our results are entirely applicable to these inducers that are less strong, we don't know. But we figure that exaggerating the response, making it really strong, might give us a better signal of what's happening. So there is variation in individuals' experience of post-exertional malaise. The data that we did surveys after the people did the 2-day CPET to survey people as to their symptoms and when they resolved, the increase in symptoms when they resolved. This data was analyzed by Jeff Moore, one of our collaborating physicians. And what he found was that our ME subjects took about 2 weeks to recover from the 2-day CPET. But the sedentary controls, on average, needed only 2 days. Some of the controls were fine the next day. They didn't have any needed time of recovery. We had some ME subjects who took months to recover. But we were sad to learn that one person, in fact, felt that his baseline was permanently reduced after doing the 2-day CPET. But most of the patients did recover, except for this one person. They all recovered to their baseline. And we did give the people all of their data so that they could use this data to document their disability. And we had some patients who were grateful to get the data because they could prove to their relatives, their doubting relatives, that they were actually ill. So when you're comparing molecules during a time course, what are you finding out? Well, if you look at the molecules in the blood that was collected before at the baseline, you're looking at baseline differences. What's usually different at any time? And then this blood that you collect here, you're looking at the immediate effect of exercise. And the differences that you see here after the exercise could be ones that are setting up people for the PEM that they're going to experience. Now, for practical reasons, we had to use 24 hours as our recovery period because a number of the people had to travel to do the exercise evaluation, and we didn't want them to have to stay for 2 nights. So we arbitrarily said 24 hours was how long they were going to have a recovery period. And for most people, this is probably correct. But as was discussed earlier, there are some people who don't start experiencing PEM for maybe 48 hours, and others who start experiencing it sooner. But this is what we had to use for practical reasons. So this is the recovery period. And then at the beginning, when they come back in 24 hours, differences we see here to the earlier stage reflect the state of PEM, that most of these people will be in PEM. Then they're going to do the exercise again, and we're going to look at the immediate effect of the exercise. And if there's a difference here that's greater than at post-day 1, then we're seeing that PEM is having an effect on the immediate exercise response. So which molecules have we assessed before and after maximal CPET? So we've looked at metabolites in plasma, plasma proteins, the protein contents of extracellular vesicles, and also the gene expression in immune cells. And given that I'm supposed to do this in about 20 minutes, I can't talk about all of this. These are our publications that are utilizing the data collected during the 2-day CPET project. And I'm going to specifically focus on the protein data, the plasma proteins and the extracellular vesicle proteins. All of this data is available from MapME-CFS. You can get an account and investigate this if you are part of a scientific organization and mine it further for additional insights. We ourselves are planning to mine the data further ourselves. So post-exertional malaise could occur because the patients are producing detrimental molecules that controls don't produce. So that's one possibility. And I was actually quite interested in that when we started to do this, because the patients really feel as if they've gotten a new illness almost. They've gotten sicker, they've gotten poisoned by doing this exertion. But it's also possible that controls are producing beneficial molecules that cases don't. So when the control exerts themselves, they're doing something to repair any damage that was done during the exercise. It's also possible that cases are having both problems. They fail to produce the beneficial molecules and they produce harmful molecules. And it's my suspicion that that is probably what's going on. So I can only give highlights and just sort of vignettes from 3 of our studies, because when I was looking at our own papers, I realized we had 79 pages of text in those 3 papers. And that doesn't even count all the supplemental data. So there's a tremendous amount of data and analysis in these papers, and you're only going to get a minuscule amount of that from a 20-minute talk. We looked at plasma proteins from 79 cases and 53 controls, and over 6,000 proteins. We got data on over 6,000 plasma proteins. The extracellular vesicle studies were smaller cohorts. We had a small cohort of females and a small cohort of males, in which we only got 301 proteins for the females and 865 for the males. So why was this? Well, we used SomaLogic for the plasma proteins. We were able to contract with SomaLogic to get that data. We used our local facility to do mass spectrometry, and their technology improved between the time we examined the females versus the males, so we got more data on the males. But the difference in an amount of proteins, of course, is affecting how we can compare these three studies, in that we had a lot more data on the plasma proteins. So this is the plasma protein study, and I will discuss a few interesting aspects of this study. What we found was not just looking at individual proteins. If you look at compared individual proteins, there weren't a lot that were different between patients and controls. But if you look at the pathways, if you look at the proteins in aggregate, what pathway they belong to, we could see that some pathways were upregulated and others were downregulated. Actually, in the plasma proteins, at the time the patients are experiencing post-exertional malaise, 24 hours after the exercise, the only one that's upregulated in the patients is glycolysis. And that is likely because the patients are having to use glycolysis rather than oxidative phosphorylation to generate energy. All of the other pathways, the patients have lower activation than the controls. And these other pathways, it's interesting to what kinds they are. There's 3 of them that have to do with neuronal function. And all these others here have to do with cell-to-cell signaling. So there's really quite a lot of signaling going between cells and different tissues that is lower in the patients than the controls. The only feature that was occurring at all 3 time points was this T cell receptor signaling pathway, which is lower in it, but our collaborator, Andrew Grimson, his lab has several papers showing that T cell abnormalities occur in the illness. So in addition to comparing between patients and controls, we can also ask, how are the controls changing and how are the patients changing at these different times? So during the recovery, I'm going to focus on this recovery period. During the recovery period, if you look at the controls, here they have 731 proteins that are increasing in abundance and 257 that are decreasing during the recovery period. The patients also, an average of 100 patients altogether are 150 decreasing and 201 increasing. So there's really within each cohort, there are changes that you can document. Now, what was really striking with regard to this 24-hour recovery was looking at the different sexes, comparing the females, looking at the females separately from the males. And when we do that, we find a very striking result. At 24 hours, the ME patients, the ME female patients, are showing a significant number, over 2,000 increasing, over 1,300 decreasing in the ME patients, in the females. But in the males, it's actually the controls that are showing a lot of increase and a lot of decrease. So these two together give you this picture here. But actually, if you separate the females and the males, you're getting a very different picture of what's happening. So you could say that, well, maybe these increases in the ME patients are doing bad things in the females, and in the males, their failure to do the things that the controls are doing might be what's setting the males and females up for the post-exertional malaise. So another way to look at this is to use a statistical method called fuzzy C-means clustering. And that allows you to cluster together all the proteins that are changing in the same way. So looking at these proteins here in the females that are changing significantly during the recovery period, you can see there's a group here that, okay, the protein goes up after the first exercise, then it goes back down for the beginning of the second, and then it goes back up. Here's a cluster in which the proteins don't change. These proteins don't change very much after the first exercise, but then they've gone down 24 hours later, and then the second exercise doesn't do much. And then you can ask, well, what pathways do these different clusters represent? And you can see that this is just, there's many, I couldn't show it here, there's many pathways that are represented here, but the top ones are immune system pathways, so immune system proteins. So the immune system is clearly very important in generating these clusters, but there's some other things too. For example, ephren signaling, hemostasis, and this one over here. So this is what the ME patients are doing, what those proteins are clustered, by this method. If you look at these same proteins here in the controls, what are they doing? Well, some of them are doing the same thing, but many of them are not doing the same thing. So you can see that the controls really are not doing the same thing as the patients. And maybe this is in fact setting up the females for post-exertional malaise. What about the males? In the males, we have to look at the controls. We can cluster the controls into these 5 clusters. And again, the immune system is what's going on even in the controls, but there's some other pathways as well, such as digestion, for example, post-translational protein modification, membrane trafficking in here. So there's different pathways that are the top ones in the controls. So these controls might be doing something good. These control males are doing something good to heal from the 2-day exercise. What are the patients doing? If we look at those very same proteins in the patients, you can see they are not doing the same thing. doing the same thing as the controls are. So this could be, in fact, something that is inhibiting the males from being able to recover. So I would like to just briefly mention one reason it was useful to do the 2-day CPET is that we obtained physiological data. And we could see that the levels of the plasma proteins at each time point are able to predict the cardiovascular fitness as reflected by VO2 max. And there were more proteins important for the ME/CFS VO2 max than the controls. So all of these blue proteins here, their levels were related to the performance on the first CPET and the performance on the second CPET. Now, there's a huge amount of data here, and I can only scratch the surface. I just thought I would show the close in on this the second CPET. So this is the CPET people are doing after they've experienced post-exertional malaise. And if you look at the level of the proteins immediately after the first exercise, that affects the performance on the second exercise, either negatively or positively. So to give you just a couple examples, these are all inflammatory proteins. This is complement, this is a cytokine. Higher levels of these inflammatory proteins immediately after the first CPET are correlated with having a lower VO2 max, performing worse in the second CPET. Here's another one that's interesting. The higher the amount of this particular protein, the better the VO2 max in the second CPET. And this is a protein that's important for mitochondrial respiration, oxidative phosphorylation. So in the little bit of time I have left, I want to talk about another component of the plasma, these extracellular vesicles. These vesicles are released from many different types of cells into the circulation, and they have proteins on their surface and inside as cargo, and they can enter other cells and affect their function. So they are like these plasma proteins that sometimes are secreted and can be taken up by other cells. And so they are also another important feature of signaling between different tissues and cells in the body. So we've published 2 papers in which we've examined the extracellular vesicles in females, as I mentioned, and in males, with a smaller number of proteins identified, yet there was still enough information in the protein assays to make some interesting findings. One of the things that we observed is that for both females and males, the most differentially expressed proteins between patients and controls occur at the day 1 post. So this is after the very first exercise. All of these proteins in the females here and the males here are different between patients and controls. And in both cases, the females and the males, the levels of the proteins in the patients are relatively lower to the same protein in the controls. There's a few that are higher, but most of them are actually lower. Another just example from this work is that the female controls had more EVs that increased after the first CPET than the proteins in the female cases. So 142 proteins in the controls increased after the exercise. That's what these are here. But only 18 increased in the patients. So one possibility is the fact 45 of them did overlap, but maybe these others, these 142, perhaps they're needed for proper recovery from the exercise. It's also possible that these 18 that are specific to the ME/CFS, maybe these are doing something bad that is inhibiting the ME/CFS recovery. Just to give you one example of some of these proteins that is undoubtedly of interest to some of the researchers out there, is that the changes in the fibrinogen chain levels in extracellular vesicles from the female cases correlate with the fatigue and PEM. So this is the change between baseline and the first exercise. There's no real, the red is the controls, and there's no real effective correlation there. But there's more PEM 24 hours post-exercise, the more you have of each of these chain proteins. So that more fibrinogen immediately after the exercise, the worse you feel 24 hours later. And fibrinogen is cleaved into fibrin to form blood clots. And as we've heard from the Pretorius group, blood clots could be an important feature of ME/CFS. Another example I'll give you is for the males. And in the male cases, the ratio of some protein abundances during the recovery period correlate with the extent of PEM 24 hours later. Now, most of these proteins here have something to do with endoplasmic reticulum stress management and protein folding. And the more expression you have of these proteins, the worse your PEM is 24 hours later. My interpretation of this is that this is saying that ER stress and abnormal proteins are being produced, and the body of the ME patients is trying to do something about this, but the controls don't need to do this because they're not experiencing this ER stress and aberrant protein folding. So some common themes are emerging from these dysregulated pathways, and these common themes are also seen, many of them at baseline as well. But it looks like all of these different pathways are potentially involved in setting up post-exertional malaise. So I've shown you that comparing patients and controls after provocation by maximal exercise can provide information about the illness state and about post-exertional malaise. What I would like to see and do in the future is actually look at what happens when you make people better. These treatment trials offer an opportunity to discover changes when patients improve. So you have patients, they're given a drug, some of them don't respond, so they stay just as bad, but you have a responder who's bad and then better. And if we can look at the molecules that change, I'm thinking we can learn additional information about this, what makes people worse in the first place. I'll end here with my acknowledgements, and I thank the people in my lab and all the patients, especially knowing they were going to induce post-exertional malaise, still volunteered to do the study. And we had great help from our collaborating physicians and exercise physiologists. Thanks.
Thank you, Maureen. Great talk as always. Lots to think about, lots of exciting data. Please put the questions in the chat. Maybe I'll kick off with a question and maybe we'll then move on to the panel discussion. That might be a better way to do this. So in terms of, do you think, Maureen, do we have to do the CPET to exhaustion? Do you think we would get a similar result if we didn't maximally exercise the patients? Or do you think that's too dangerous to do studies on a lower scale?
Certainly you don't need to do a 2-day CPET to induce post-exertional malaise. And there are people doing other ways of inducing post-exertional malaise. For example, Loughborough has a massaging device that will cause people to experience post-exertional malaise. There are people who do much more limited challenges that induce post-exertional malaise. The real reason we wanted the 2-day CPET is so that we could get the physiological parameters that you couldn't get from just massaging someone or making them do maybe a 3-minute step up and step down, which is used by the Harvard group. But I don't think it's required, and I mean, it definitely is not required. The advantage that we did get from doing this was having the physiological data, looking at maximum. We could correlate things with maximal heart rate, with anaerobic threshold, with VO2 max, changes in blood pressure. So that's why we really wanted to do it. But yeah, it is definitely not necessary for studying post-exertional malaise.
Okay. There's no questions in the chat. Anybody from the panel want to ask a question? Chris, Todd, anybody? Because you're the only ones with microphones that can be turned on. So I don't know, in the last 5 minutes, anyone's got a question? So just quickly, Maureen, so the glycolytic upregulation you saw. Was there anything that you saw on the proteomics that came out as a clear change, or was it just a general increase? Like, because there's this idea that there may be some sort of hypoxic type response going on in the patients. I wonder whether you saw anything that could link to that with the glycolytic
Well,
proteins.
definitely there are some genes related to hypoxia that are changing, and some proteins, both genes and proteins. So there's definitely indications of hypoxia. And of course, the other tricky thing is we are looking at plasma proteins. We're not looking at cells. So we're seeing the upregulation in these glycolysis proteins in the plasma, and why that is, we can't entirely interpret why that is.
Sure. I think Marie's got a question. Do you want to come on?
Yeah, thanks, Maureen. When I see differences between males and females, I often worry that there's some sort of artifact going on, and then I wonder what's causing that. I'm wondering if you've got some insights and whether you looked at the menstrual cycle phase in the females to see if there was anything happening there.
And that's something that we did not capture. So we did not look at that. And in retrospect, we wish we had, but we didn't actually gather. That's some data that we didn't gather. As everyone here knows, females are more likely to have ME than males. And so there is some difference going on there that we don't understand. The differences in the plasma proteins were like you were almost looking at two different species, like two different animals. So we were very surprised to see that. But there are other studies showing differences between males and females. One of the problems that we have in ME was with the lack of funding. It's very hard sometimes to capture enough of both sexes to have a large enough cohort to actually separate them. And we've had to do a number of studies because of lack of funding that are females only, because it's hard to do a lot of these molecular assays. So one thing we've done is, in fact, sometimes confined to either females or males.
Great. Maybe just one last. So in the department I work in, they do a lot of work on preeclampsia and looking at EVEs from preeclampsia. And they found some really interesting sort of half tRNA molecules in some of their EVs. I don't know, has anyone looked at that in MECFS? I know Alan Moreau's done some RNA, just general RNA, but has anyone specifically looked at tRNAs?
Yeah, I don't know of anyone who's looked at tRNAs. We would like to look at, we have done some work with our collaborator, Andrew Grimson, on microRNAs and small RNAs, but I don't recall any information about half tRNAs. But that's interesting, something to consider for sure.
Okay. So I think we've come to the end of the questions. So maybe the panel want to come back on and we can have some concluding remarks. Maybe people might want to just give Daphne, how do you want to run this part?
I think if there's no further questions, then we'll bring the webinar to a close.
Yeah, unless anyone, Chris or anyone's got anything on the platform. No? Okay.
Someone did ask whether UK researchers can access the data. Anyone who has an account who is associated with the scientific organization is able to access the data. Unfortunately, because of NIH rules, you do have to have an association with a research organization. But as long as you do, anyone in the world can can get an account and access the data for further analysis.
Can I just jump in and thank all the speakers and the organizers of today's meeting? It's been fascinating. And those attendees who may wish to propose further PRIME webinars in the future, please do let us know what you'd like to hear about. Thank you.
Thanks. And we have a provisional date for the next webinar. So that's the 28th of October. And the theme will be the neurology of ME/CFS, and we'll be sharing some more details on the Action for ME channels very soon. And again, if you want to find out more about PRIME, upcoming webinars, the conference, or public and patient involvement opportunities, then feel free to click on the link that I've just put in the chat.
There's one question about cortisol that I missed. I don't know if anyone wants to come in. So basically, has long-term high cortisol levels ever been associated with PEM? Has anyone seen that? I'm not aware of anything. No, shaking of heads. So Ruth, so nobody is aware of that. Someone's got low cortisol levels. Okay. Anyway, thanks everybody.
Great. Thank you very much, everyone.